invite to this podium Dr. Nenaya Kalu, who represents the Director General of the NHIA, Dr. Jimmy.
My name is Dr. Nenaya Kalu. I'm the TA to DG NHIA, and I'll be talking briefly about the health priorities in Nigeria's Multidimensional Poverty Index, the status and the challenges. Widening the gap between the rich and the poor. Now, within the context of the Multidimensional Poverty Index, I'm not sure how many of us have really had time to go through it. But under health, you have three different indicators. You have nutrition, food insecurity, and time to healthcare. Time to healthcare is like the most important one, the one that has the highest scoring. But let me start with nutrition. Now, a household is said to be deprived if any child under the age of 5 is undernourished, or if you have an adult household member with a body mass index less than 18.5. Now, when it comes to food insecurity, there's this bank of about 8 questions we ask in the last 1 year. Have you ever gone to sleep without food? Have you ever eaten less than you should, even though you're hungry? You know, all these questions. And when somebody in that household answers maybe 7 out of 8, okay, that's severe deprivation, food insecurity. And then time to healthcare, which is given the highest score, is rated as, there's a deprivation when it takes somebody in a household more than 30 minutes to get to a healthcare facility, a functional healthcare facility on foot. I don't know how many of us here in this room live within 30 minutes on foot from a healthcare facility. Not just anyone, but a functional one that can give you everything that you need. I'm sure if you are here, you're in the minority. So like I said, time to healthcare contributes to most, followed by food insecurity, school attendance, and nutrition. Even though school attendance is not under the health, it comes under education. The other dimensions, so there's health, there's education, we have living standard, and then we have work and shocks. School attendance counts when somebody, a child within 6 and 15 is not attending school. And that really counts because education is also important for health and productivity. Now when it comes to living standards, we have water and sanitation. And we know how that is also important for healthcare. In fact, if you want to improve healthcare in Nigeria, and you make sure that everybody in Nigeria has access to good, clean drinking water. We live in a very clean environment. Condition is perfect. We all attend school. You could easily cut the number of Nigerians that are sick or not healthy by more than, in fact, I don't want to put any figures, but you could really cut it down. So those are some of the things that are covered in the Multidimensional Poverty Index, apart from also unemployment, underemployment, and security shock. Just to put that out there in case some of us haven't gone through it in detail. Now, focusing on nutrition and food insecurity. In January 2024, I think I'm on slide 7 now. I don't know if that's clear. Nigeria's food inflation surged about 35.41%. And between 2023 and 2024, from 66 million Nigerians who were food insecure, it surged about 100 million in 1 year. So now, it would have even gone higher. So that tells you how food insecure a lot of people are in Nigeria. And malnutrition affects more than 32% of the children under 5, contributing to high rates of child mortality. During the morning session, we talked a lot about things that are driving food insecurity, poverty, limited access to credit, herdsmen, farmer clashes, climate change, limited investments in mechanized farming and all that. So even the food storage, a lot of food is being destroyed post-harvest. So those are things to consider when it comes to the issue of food insecurity. Slide 8. So time to healthcare. I want to really narrow down on this. There are so many barriers to seeking healthcare. And I'm sure we're familiar with the geographical barriers, the distance. We talked about 30 minutes. Most facilities are not within 30 minutes. You still have to pay for transportation costs. What's the state of the roads? Are there ambulances in case somebody is here? So all these things are part of the geographical. In terms of financial, a lot of people will not leave their homes until they are sure they have the money to even go to the facility to pay for care. How many people are covered by health insurance? Even though we made a lot of inroads over, this is not working. So even though we made a lot of inroads over the last year and a half or so, we have been able to increase health insurance coverage across the country, both private and the state and the national level, from 16 to over 20 billion. but there's still a lot of room for improvement, especially the missing middle, the non-poor informal sector, and then the vulnerable groups who need to be covered. We look at structural things, those barriers. You get to the facility, okay, fine, you have been able to get there. You have your money in your pocket. Maybe there are no human resources for health. There are no drugs. There are no equipment. So many things are wrong. There's no light. So all those things are also important as well. And then there's also the cultural barrier. What do people perceive about this healthcare facility? Do they want to even go there to access care in the first place? How do they perceive the attitude of the people, the health workers, and so on? So a lot of things to think about. Even though the MPI only talks about time to healthcare, but there's so many other barriers that affect time to healthcare. There's also the opportunity cost. For me to go to a facility, what am I giving up? Do I need to forgo one day of work? Because people complain that I go to the hospital and I spend the whole day there from morning to night. I've lost income for that. Particularly in the informal sector, people end day to day. And then caregivers, a lot of people, particularly in our own context. Like I said, we have a high dependency ratio. So somebody has to take that patient to the facility. Yes, whether it's a child or an aged person or a sick person. That person is also foregoing a whole day of income. So we have to consider that as well. The caregiver group, does he know how important it is to take the person here? Does he even have the transportation money to go there? Is he empowered at all? Does he understand the symptoms? Does he know? So there's so many things that we have to take the caregivers into consideration. And then lastly, I put the three main delays in seeking healthcare, especially for obstetric emergencies, because we have high maternal mortality in Nigeria. Delay in deciding to seek healthcare. Making that decision is one. Delay in reaching the facility, and then delay in getting care even when they get to that facility because of the bureaucratic bottlenecks and the finances as well. So what are the key drivers? Next slide. The key drivers, or the main things to look at: poverty. Next slide. Poverty is at the center of it all, and everything is linked to poverty. We talked about limited health insurance and social safety net coverage. We've talked about the human resource issues. We talked about information gaps, limited education, and then also the infrastructure gaps. Limited financing. Poverty aggravates everything. So it's something that links all, and that's why we're here to talk about poverty. How can we begin to address poverty to make sure that people can afford health insurance? At least those who can afford to pay should be able to pay. And then those who cannot, how do we get the money to pay for them? How do we ensure that all the facilities are well funded, that they have the drugs that they need, that they have the equipment that they need, they have the human resources that they need? How do we make sure that the right information is out there, it's appropriate, it's adequate, it's correct, and that we have the right mix and distribution and capacity of healthcare workers that we need? Next slide. I just want to show, the next slide shows the Federal Ministry of Health Strategic Blueprint. And one of the things there, it has pillars. Pillar 1 is effective governance. Pillar 2 is efficient. Next slide. Efficient, equitable, and quality health system. Pillar 3 is unlocking the value chains, and Pillar 4 is health security. Now, under the slide, the second pillar, the first thing there is driving health promotion in a multi-sectoral way, looking at education, environment, water and sanitation, and nutrition. So nutrition comes out clearly here. But before we even get there, if you go to the top there, it says our goal as the Ministry of Health and all its agencies is to save lives, reduce both physical and financial pain, and produce health for all Nigerians. So reducing the financial pain is another way of saying reducing poverty. So everything, all the pillars, everything we're doing is linked towards saving lives, reducing poverty, and making sure that we produce health for all Nigerians. This is better. So poverty is here, is considered here, and then under each of the pillars, it speaks to different things. Like I mentioned, nutrition is under pillar 2, even health insurance is also under pillar 2, health security is on its own, and then the cost of the infrastructure, the drugs and everything is under pillar 3. So just to highlight this. The next slide shows NHIA, how we draw from there. And our own goal is to bring millions of Nigerians out of health poverty. Now we may sit here and say that we are not health poor, but every one of us is just one catastrophic illness away from poverty. All it takes is a diagnosis of maybe, say, cancer, And by the time one finishes all the investigations, getting the drugs and everything, one is pushed further into poverty. So how do we bring millions of Nigerians out of health poverty? And for us, we have 4 pillars as well, which is to expand coverage by emphasizing and promoting the adoption of health insurance, improving equity by implementing equity programs, and we have a few of those, the fistula-free program and financing access to comprehensive emergency obstetric care, both of which are already running. We have about 16,000 women that have benefited from the emergency obstetric care and 3,000 women who have benefited from the fistula repairs under the FFP. Then we're also improving the quality of care, incentivizing the quality of care through strategic purchasing, and then improving market efficiency, making sure that we have a sustainable system as well. And not doing that, we're leveraging data and technology, citizens engagement, and optimizing organizational health. So next slide. What are the opportunities? One of the things that happened recently is that we had a national health financing dialogue. A lot of things came out of there. How can we get more money for health and more health for money? We've talked about increasing the BACPF, the amount that is available, looking at health taxes, and so many other things. So the political will is there. Even Mr. President came out and said that all MDAs should fall into health insurance with immediate effect, and then the private sector should be engaged. So political will is there. Do I have a right to a certain minimum benefit as a Nigerian when it comes to health insurance or access to healthcare, when it comes to pension, employment benefits, and other things? What am I entitled to? We need to be able to define that in the country and implement that. Data management systems are research agenda. We have different data sets in silos. How do we bring them together? Okay, our time is almost up. How do we use that to generate evidence? And then local production of medicines and equipment, very important. How do we reorientate people towards health promotion and disease prevention, not just curative care, so that we can cut down the cost of hospital stay and then repurpose that funding? And then also, how do we prioritize other determinants of health? Like I said, if everybody in Nigeria has access to good water, good housing, good food, it will cut down a lot of the people who are seeking care in hospital. And then most importantly, we also need to strengthen the supply side. It's not enough for us to just make it easy for people to financially access care. And when they get there, they are not getting the care that they need. They must be sure when they get to the facilities, there's somebody who can attend to them, their drugs, their equipment, and there's everything that they need. So these are the opportunities that we can be looking at, and some of the solutions we'll be bringing out, and we can leverage these opportunities as well. So in conclusion, last slide. So we need African solutions to African problems. Nobody knows our context more than the people in this room. We know the challenges, we know the issues, we are living it. So nobody else can do this for us. So we are here to look for African solutions, and our future is in our hands. Thank you so much.
Thank you. Thank you, Dr. Kalu. Very interesting presentation. And the question is, what must we disrupt so that our place of birth does not determine our survival? This question is very important, and we've always asked this at next year health practice. That what is it that we must do so our survival is not determined by our place of birth. We appreciate you for this wonderful. We're so sorry. We're trying to fix the ACs. I understand the place is hot. So we'll just go straight to the panel. And the panel will last 30 minutes. And I'm sure we have brought in some very distinguished fellows to do justice to the concept and the entire presentation by Dr. Kalu on behalf of Dr. Ohiru. So permit me please to invite to the podium Dr. Ifunanya Ilodipe. Dr. Ifunanya Ilodipe is the Chief Executive Officer of the EHA Clinics. You're welcome. Let me also welcome Dr. Simeon Oyemachi. Dr. Simeon Oyemachi is the Executive Secretary of the Anambra State Health Insurance Agency and also the Chairman of the Forum of CEOs of State Social Health Insurance Schemes in Nigeria. You're welcome, sir. So my name is Jim Chan Fabong once again. we'll just go straight. We will take the first question on bridging access gaps. Over 40% of Nigerians live more than 5 kilometers from the nearest health facility. Dr. Ilodike, what specific scalable strategies can close these geographic gaps, especially for rural communities without overburdening the existing systems?
Healthcare is always happening. It may not always be happening in the hospitals, but people are having healthcare happen. And when we talk about 5 kilometers, we know that that is not a sustainable thing. So how are these people getting healthcare? Healthcare is happening. Somebody is offering that healthcare. And when we think about what is scalable and what is sustainable within our context, it is healthcare that is close to us. I happen to also come from Anambra State. And in my community, there is a PPMV there that with all my degrees, my grandmother thinks he knows everything. I happen to know his name because he's been there for ages and his name is Oliver. But no matter what I do, all my big books, when Oliver gives medication, Oliver's medication works. I don't know what I'm talking about. What does that mean? Healthcare is a game of trust. It means that people will go where they trust and they will go where it's close to them because those people are in those communities offering care every day. Dr. Nana said something important. We need to come up with African solutions to solve Africa's problems. With the infrastructural issues that we have, as much as we are investing, we know that ending poverty is a long game. 5 kilometers will be a reality for a long time. So how do we bring healthcare to the people in those communities? At HA clinics, we look at people like Oliver, those community health extension workers, those PPMVs that are already within the communities offering some kind of care. And we ask ourselves, how can we help people like this provide a level of quality care that is still sustainable within the communities? That, guess what? Even if today I go and build a hospital in my community, everybody will pass, people will come and look at it. Most likely they'll still go to Oliver for care till they can trust it. So when we look at those communities, we look at how can I equip people like Oliver with artificial intelligence and clinical decision support so that they can triage patients, they can make some level of informed care and also be able to triage and refer patients early so that patients present earlier and come up with less complications. How can I use people like Oliver to run MCD programs so that people can go there every day to check their blood pressure and get their medication? How can I use people like Oliver to provide vaccination? Because we know that one of the problems with vaccination, as well-funded as vaccination plans are, is trust. Because there's a lot of vaccine hesitancy because there's a lot of trust issues. But guess what? Oliver is not moving out of that community. So they know that if Oliver gives them that drug, he's not going to run away. If there's a problem, they can come back and tell Oliver, that medication you gave me has problems. So when we think of solving Africa's problems, it is how do we bring healthcare to them in a way they trust, with the people they trust, using digital tools that are affordable, made for Africa, and are hence sustainable. Thank you so much.
Dr. Yemachi, I worked closely with you while we worked together in providing financial risk protection to our people in Nigeria. And you agree with me that over 70% of healthcare expenditures are out of pocket. Now, with the question of financial equity, What do you think we can do? How do we redesign? How do we create some financing models to ensure that no one is left behind? Thank you, sir.
I want to look at it from the point of view that Dr. Nena drew in, talking about summarizing what happened at the health financing dialogue. It's not just about the money, but then it's about more health for the money that we have available. Currently, we have some idle funds that potentially supposed to do a lot for the health space. I keep asking one question. You give me, for instance, 25,000 naira as a 65-year-old hypertensive diabetic through the conditional cash transfer programs. And then I have to take my oral hypoglycemics and the antihypertensive drugs that Dr. Nena spoke to, and said clearly that if you do not have the finance to take care of that, you will have days when you will skip or even get to a point where you discontinue completely. The bound hypertension, the effect of all of those, as health personnel, we know that too well. That these individuals could then come down with complications, sequelae of disrupting these medications that should be for a lifetime. And you hand this person down 25,000, for instance. Very laudable initiative. You have used certain indices to identify this person as poor and vulnerable. You haven't taken care of the health care need of that person. He or she will buy the medications the days when they care to, and then on some other days they skip it. Simple logic. Can we say, in every state today in this country, we have functional state health insurance schemes, 36 states plus FCT, at different levels of functionality. I must concede, as the chairman of the forum, where I sit, I can dissect to say, using objective matrices, these states are doing very well. And then these other states are not yet where we desire as a forum that they should be. However, is there anything wrong in allocating a certain fraction of that 25,000 to say, let us enroll every person who we have identified that is qualified for these social interventions into health insurance to take care of their health care needs? Because we all agree, literature is very clear on it, that healthcare expenditure could either tilt the man who is still normal into financial hardship, and the one who is already facing financial hardship can become impoverished. It is not lost on us. We are all, like she alluded to earlier, one major illness away from becoming very poor. Every one of us in this room, including those of us who think that we are doing very well. And she gave a catastrophic health expenditure case of having cancer, for instance. How have we ensured our health care with the monies that are present already in the system? It's a conversation, a practical solution that we can begin to deal with, and millions of Nigerians will come on board the health insurance pool. Having said that, we have in the country different models that have worked. About 20 million Nigerians today have access to health insurance. And each time I'm confronted with this question in different fora, I say, listen, if we do the needful with supply side, we will get more Nigerians paying for health insurance. My sister here talked about the trust for Oliver in her community. How many of Olivers can we get in our various healthcare facilities across this country? We have basic healthcare provision fund, taking care of healthcare in the way it was ideated. To bring it closer, in every political ward, people should be able to walk to facilities to access care. But what is the quality of care they get in those places? You have CMDs say clearly to their CMATs and heads of clinical departments, when the health insurance card-bearing patients come in, give them less drugs or less quality drugs, or even say to them outrightly that these drugs are out of stock. And in the same facility, when you bring out your wallet to pay, what they told you was out of stock suddenly becomes available. Why will that person go back to say to his brother or sister in the village, oh, health insurance is the way to go? There are lots of disincentives from the health system. And these individuals, when they are denied care by these providers, will turn around to blame the funders of the health insurance. My brother here was CEO, Director General of Plateau State Health Insurance Management Authority before he left in his former life. When he was there, he had a very robust system. If you ask him, I can tell you for free, I've been on this job for 7 years and a half. The one headache of every one CEO of a state health insurance scheme is this: we pay you as and when due. Your capitation, your fee for service. Why do you go on denying our beneficiaries care when they come in? Solutions. We need in the short term to have service level agreements that must be enforceable. Going beyond signing MOUs with healthcare providers. How can we enforce SLAs? But then even if you have SLAs that are supposed to be enforced, are the citizens aware? You get the beneficiaries of these health insurance schemes who go there, they complain and just pay. Just like seeing a policeman, and rather than just be patient to check your particulars, the average Nigerian just wants to say, let us keep moving, please stay. And then you turn around to blame the police officer for being involved in bribery and all of that. We are impatient. There are uses of technology across the states and the NHIA-driven health insurance schemes that we have. How have our citizens engaged with those feedback mechanisms to see them work? I was in medical school, nobody taught me about health financing. Nobody. And I came out of medical school about 19 years ago. Nobody taught me health financing. How can we in the long term go to the curriculum of every healthcare worker in training, pre-service training, to put very critically that the way to go is strategic purchasing? Let us reduce all of these inefficiencies. If we have health insurance working, it will take care of health promotion, health prevention, and even the curative care and what have you. Several countries that are serious around the world, what they have done is to get health insurance to work, and then the ministries of health spend their time dealing with health promotion and health prevention at a global stage. We can do some of this, and Nigeria will be better for it. Thank you.
Thank you, Senior responded like Olufalaye. If you ask Olufalaye one question, he will give you answers to 10 subsequent questions that it's meant to be asked. Yeah. Yeah. So, you said that Oliver story is really captivating. By the way, every village here has an Oliver, isn't it? Yes. Yes. As a matter of fact, before people started trusting me as a doctor, it took ages until Oliver couldn't do something, and I did it in the village. So that's when they said, okay, now we know the difference between the true doctor and Oliver. Now, but of course, Oliver is bridging the gap in human resources for health. The statistics has it that we have just 4 doctors by 100,000 people, 16 nurses by 100,000 people, and we discussed trust deficit here, we discussed issues of training, issues of building confidence, and the likes. But you rose through the rank from a low officer to a mid-level officer to a chief executive of the EHA clinics. I went to your space, an amazing model. And then you discussed how we need to bring in AI and telemedicine, which borders on data, borders on consultation remotely, and the like. So I want you to throw in some practical insight into how do we adopt, albeit slow, how do we adopt AI, how can we improve on human resources for health, though you had touched on the fact that it's not the question of bringing in more facility. How can we leverage on the already existing stuff to deliver nothing but the best?
I'm sorry, this is not.
Yeah, so you can discuss.
Thank you very much. I love how Dr. Minechi speaks so passionately. So every time I think of human resources health and health financing, I think it's the proverbial which came first, the chicken and the egg. It's a vicious cycle, right? Because financing is poor, there are workforce shortages, and the workforce that exists, we can't pay properly, we can't incentivize to stay, so people go to the healthcare facilities. The workforce that is there is poorly trained, they're demotivated, so they offer worse quality of care, so people don't want to pay to go there, and the cycle continues. So figuring out how to finance healthcare, it's not just a health equity issue, it's also how we can solve workforce shortages, right? Because we need to be able to pay for better care. We need to be able to pay to have doctors. We need to be able to pay to have medical schools. We need to be able to pay to have medical schools that graduate doctors. I mean, I went to medical school in Ghana, and I remember one of the incentives that they had for doctors, beyond the fact that the government covers for some doctors 60% of their tuition, which means that at the end of medical school, you have a certain number of years you have to give before you can leave the country, or there's money you have to pay off. They offer things like no customs duty on vehicles imported by doctors, tax breaks, incentives for doctors and healthcare workers to stay. So there's that, and how we think about how we optimize workforce. But it's a long game. So what do we do in the interim? When I talked about AI and telemedicine, it's very important that when you are designing any kind of technology, you design it thinking about the population and with the population that you are trying to intervene with. There are a lot of, if you go to a lot of healthcare facilities, and I know if you do this around the country, you see a lot of equipment that is just there. You come and somebody comes and says, oh, I'm donating 5,000 computers, and there's canopies, and everybody claps, and then we all have, we cut the ribbons, and then we put the computers down because we didn't think about how people are going to use it, how we're going to do power, how data was going to be, how we're going to subsidize data so that it's not very expensive to use. So we need to think about data infrastructure. How can we make data cheaper and more affordable in those communities so that adoption is easier? And then in the way we even design these AI and tools, is it easy to use? It's very nice to design something and bring it, but let me tell you this, if it is easier to write in paper, people will not use it. That's just what it is. How many of us have things that they show us on our phone, an application, and we press this. By the time we get to the sixth part, we're like, I beg, this thing. Because the user interface is not easy. It's not intuitive. It's not easy to use. It is outside how the patient's journey is. I always say this, that, when during COVID, telemedicine was the thing, and everybody was creating telemedicine companies, and everybody had telemedicine. But today, where are those companies? Because at the end of the day, what we did not imagine was, how does telemedicine fit into the patient journey? How do we solve, beyond the process of talking to a doctor, where are the patients going to get labs from? How does this doctor over the computer get the lab results and make an informed decision? Where are they going to get the medication? Is the medication going to be good quality? So every time we think of the adoption of any digital tool, we have to remember that it's not a single interaction. The patient has a journey with the healthcare system, and we need to think about how that tool enhances the journey and not just make it add more bottlenecks and more roadblocks. So those are the things I think about. And with adoption, with healthcare workers, how are we training them and retraining them to use the health? How do we even incentivize them to use these tools? Are these tools actually making it faster, or is it making it more complex? And when that data that they get from using those tools is generated, how do we use that data to measure outcomes? Are they actually improving outcomes? Do we feed back to the healthcare workers and say, these things are improving outcomes? How do we incentivize those outcomes? One of the things that Dr. Yemichi said is so true. At the end of the day, patients go to these hospitals and get care. What kind of care are they getting? You're paying capitation on what kind of care? Is there now time to think about how do we incentivize the quality of care that patients are getting? Is hospital A and hospital B, when they provide care, if hospital A is providing better care according to the quality matrices, do we not pay hospital A better so that hospital B tomorrow sees that if I get better care, I'll be paid better? Then guess what? Hospital A has more money to hire more doctors, has more money to hire better nurses, and then the cycle continues. Thank you.
Thank you, Simeon, governance and accountability has been a very, very huge challenge. Until of recent, we operated in silos. Poor coordination from federal government, state governments to local governments, but I can see some concerted efforts with the sector-wide approach where we are tending towards having one conversation, one budget, one plan, one M&E. Albeit slow, but it's something that I think will help us in the future. And again, the last, what we call baseline interventions that we did, we touched on the questions of governance and accountability, and we discover from the preliminary reports that that is very way on the lower side, leading to resource misallocation. Now, sir, which governance reforms and accountability mechanisms are vital to ensure that health systems investment produce measurable outcomes? Thank you.
Yeah, thank you for the question. Quite frankly, I must seize this opportunity to commend the vision of the Honorable Coordinating Minister for Health and Social Welfare, Professor Mohamed Ali Pate, for the initiative which you just touched on, the health sector renewal investment and health sector renewal investment initiative that he's running with, especially the creation of SWOP, the sector-wide approach in the past. And we still have some silos of that, pockets of that happen. People operated in silos, territorialism. This is my turf. Do not get into this field. I prefer particularization of programs. Let us implement with the funding of US government or EU or whichever funding partner. And that's why sometimes when I say this, colleagues look at me and then they shudder. I am very happy, and I don't want to be, I won't say I'm misquoted. I am very excited that today we have some of the policies of the US government withdrawing these donor funds so that we can really begin to plan, have one conversation. Where are we? And then, because it's, if you do not know where you are, quite frankly, you won't know where you're going to. Everywhere will look like the road. A lot of our data here, we are what really is driving the kind of statistics we churn out. Are there dollars, donor dollars, that are driving the things that we are churning out? We need that accountability from the point of identifying our problems. If we have that level of integrity with our data, then we can then begin to do proper root cause analysis to figure out what the proper solutions should be. So, for me, as a person, it's not a group thing. This is for me. I am happy that we can begin to have frank conversations among ourselves in the health space today. Having said that, it is important that the citizens should know clearly where we are going. There is no accountability without the people. The role of CSOs, CBOs, you cannot understate. But one challenge I have is, again, sometimes you have, I'm sorry, this may be anecdotal, but you have certain community-based organizations that just chase after these donor dollars. You do not really have a clear-cut identity. What is it you are really standing out for? What citizen-based awareness creation effort are you making? What is it that you are trying to do to hold those of us in government accountable? But then you chase after, get me this indicator, I have research assistants. Oh, and then the staff of the CBOs are running all around to chase. These things get me sick. Let us truly now run at our own pace. If I'm a CBO, I have my objectives, my goals, the big picture, what I want to do, let me go and do it. Understanding that, yes, I am here to hold you accountable. The government money, there's no more donor funds, so we can't have duplications. We had very crazy things in the past, in very recent past, where a donor is buying this chair, and then it is in government budget, and I will still go and buy this chair. And then it leads to what Dr. Elodibe was talking about. You get into facilities, you have equipment that are not being used. Some have been bought 10 years ago, nobody is touching them. Because we just kept procuring all manners of procurement that we didn't do on the basis of need. So we need to first be accountable with regards what we say our priorities are at the time of planning. Today with the swap, we have had it cascade down that for once we are sitting down with local governments. That's why I said I commend the Honorable Coordinating Minister. In Anambra, for instance, we sat down with local governments, all of the supervisors for health, and then the local government chairman. We sat down to really iterate what are the peculiar health challenges you have in your local government. We have our state development plan. Where are we with regards to tracking? What are those local government areas of high priority? What are the interventions that will give us high impact when we really do, when we go out to implement them? The state government actors were all in the room. All of the parastatals of health sector were there with the education guys who came in a local government service commission akin to what the Rwanda system is doing, where you have Minalog working with Ministry of Health and Ministry of Finance. And we look ourselves there, Ministry of Economic Planning, Budget, and then every one of us stakeholders. We have developed one document for Anambra that is, and this is not just Anambra, across all of the states of the Federation, with technical assistance from the federal government, the SWAP office. So, such that today they are doing a MAMI program launch, and you have all of these stakeholders in the state. There's a MAMI workshop going on currently in Anambra, and I know across the states of the Federation. And inside those rooms, unlike in the past, where some people sit in air-conditioned offices to churn out policies that does not reflect what happens on ground. And I say this mindful of the fact that I used to be here. I was the staff of the Ministry of Health. And then we sat down here to think that we knew what the people needed. Until I went to the state as special advisor to the governor on health. I realized that, look, guys, we were just sitting down talking, permit my language, rubbish. We knew nothing about what the people were suffering there. We had these beautiful policy documents. So each time I now get people come from Abuja to come and speak those English, I say, excuse me, I was one of you. Can we drop this thing and then get to the communities to actually know what these people truly need? So we need accountability and transparency in terms of even identifying the needs of the people. That will help us to then allocate resources efficiently that will give us effective outcomes in the future in a holistic manner, which I think SWAP is doing for us. Thank you.
Thank you. Simon, beyond the fact that he's a doctor, he's also an academic. Please let's clap for panelists. If you give Simeon the time, Simeon will lecture forever. I understand that we are expected to take questions for the panelists, but we have really overshoot the time. So I want to thank Dr. Ifunanya Elodibe and Dr. Simeon Oyemachi for being here with us today. We'll just take 10 minutes, I think, to just look at the workshop briefly, and then we can proceed to the main topic. If you have any questions, probably we should ask during the workshop, and it will strengthen what we intend to. So the essence of the workshop is to brainstorm from Dr. Kalu's presentation, for the insight that we have from these panelists, to have some solutions to some of the problems that we have envisaged. So, I think, Dr. Imachi, thank you so much. Thank you, Dr. Z. Dr. Lupe, thank you so much. And Dr. Z. Please let's clap for